So we are so lucky today to have Dr. Deborah Ottenheimer, who is going to be speaking about SGBV in the context of COVID-19 and forced migration. So I'll go ahead and give a little intro, and then Dr. Ottenheimer, please feel free to take it away afterwards. But Dr. Ottenheimer is currently the Director of Women's Health Services at the Morrisania Diagnostic and Treatment Center, one of the largest of the NYC Health and Hospitals Health Centers. This service provides obstetric and gynecologic care to at-risk women in the South Bronx, including a large immigrant population. The focus of Dr. Ottenheimer's work is the development of culturally competent and linguistically appropriate women's health services with cross-sectional collaboration with other medical specialties and community organizations. In addition to her clinical practice, Dr. Ottenheimer spends a significant portion of her professional time assisting asylum-seeking women who have suffered sexual and gender-based violence and other human rights violations. She's an active member of Physicians for Human Rights and serves as faculty at the Human Rights Program at the School of Medicine at Mount Sinai, the Weill Cornell Clinic for Human Rights, and the CUNY School of Medicine Human Rights Collaborative. To date, she has performed 125 forensic medical evaluations. She's published and lectured extensively on human rights violations against women with a focus on FGMC. She's also worked in Haiti, Rwanda, and the Democratic Republic of Congo, helping to improve the health and lives of women in low resource settings. And sorry, I realized I forgot to introduce myself. I'm Sneha. I'm a fourth year medical student at NYU. Part of this committee as part of the Student Advisory Board for PHR. And I see Lauren Marcel here, who is currently driving, but is also one of our committee members. So just wanted to give her a little shout out as well. But Dr. Ottenheimer, truly thank you so much for being here and for taking the time. We're so excited to hear from you and learn from you. So please take it away. Thank you for being here.
Yeah, my pleasure. I do have a quick question because Sneha and I were speaking earlier about, I don't want to be redundant to what you all already know. So maybe in between bites of your dinner, you could either chime in on the chat, which hopefully Sneha can see because there's too much on my screen right now, or raise a hand if you guys have all watched the prior recordings that are on the website, just so I am not too redundant.
Yeah,
and
so
we're also a small group, so I'm also happy for you to unmute if you're in a relatively quiet place and we can have more of a conversation.
yeah, feel free to post in the chat just so we can get an idea. And I see Victoria has also joined. She's also a member of our committee. So hey, Victoria, thanks for joining.
I have not. Okay, so seems like we're in the middle, right? I haven't. So
But, yeah.
You know what we'll do is we're gonna go through some of the slides that are a little bit redundant to what's on the website already. People for the recording can fast forward if appropriate, and people can always interrupt or say, let me know that you already know this piece. Okay. So we're gonna obviously talk about sexual and gender-based violence and the impact of COVID-19 and forced migration, which are also intersectional sort of global disasters, right? I don't have any conflicts of interest. I'm supposed to say that, so I have said it now. And we're not going to talk about any drugs, so we don't need to worry about the second part. Generally speaking, since you guys have your cameras off, I think I'm going to just minimize the window. But Sneha, you can tell me if people turn cameras on, and then I'll be able to see everybody again.
Will do.
We're going to talk generally about sexual and gender-based violence, which is the piece that I wanted to be sure wasn't redundant for the majority of the group. We're going to talk a little bit about the forces behind increases in forced migration, the intersectional effects of forced migration and COVID-19 on sexual and gender-based violence. And then maybe we can have a conversation about intervention strategies. I think sometimes there's a sense of helplessness at the end of these talks, and you just sort of want to crawl under a table. The other thing that's important is that I can't seem to get the toolbar on my Apple computer to go away, but so I can't see the very bottom. But remember, and with some apology, that almost all of the data that is collected around the world is in the gender binary. It's almost all heteronormative. And so I'm going to refer to women, and I'm going to probably mean people who are born with female external genitalia, who have been identified by other people as women, not necessarily that they identify as women. And that's because that's how the data looks. So that's what we know. So generally speaking, there is a conceptual framework for sexual and gender-based violence, which is also a little, it's false. We tend to divide it, as, again, for data collection purposes, into physical, sexual, and psychological. And right off the bat, anybody with eyes and a heart knows that there's a lot of overlap there. But that is, again, how the data gets collected, and it tends to be how we talk about it. But obviously, those categories are not clear cut. What we do know is that most women and girls suffer multiple abuses at the hands of multiple perpetrators over their lifetimes. And I would say, again, that this statement applies also to the LGBTQI community, but the data is much less robust in that space. And we also know that men and boys suffer a lot of sexual and gender-based violence, but we don't talk about it. In most cultures, it's really quite taboo, and the data is just beginning to be collected. So again, just an overview about why I will talk about women and girls and what exactly I mean by that, with an acknowledgement that that's not the whole picture. So sexual and gender-based violence is a multifaceted phenomenon. It takes a lot of forms. It does, as we've probably beat to death now, affect women of all people of all genders, ages, and sexual orientations. And it usually occurs in the context of a lifetime of persecution. And we know that it increases in settings of social crisis. So COVID-19 is the big social disruptor at the moment. Forced migration is another one. Armed conflict is a reason behind forced migration. So is climate change, but that's a different lecture. But there's a lot of evidence that climate change has increased SGBV as well. So we're going to borrow a little bit from PHR. We do not know, for all the reasons previously stated, really the prevalence of sexual violence. We as providers tend not to ask the question. People are embarrassed, they don't report. Only the people who end up in the hospital or in front of a doctor for whatever reason are counted. We tend to think about rape as the sine qua non of sexual violence, which it is not. And when people die from the abuse that they've sustained, which may or may not have included sexual and gender-based violence, they don't get counted because they can't answer the questionnaire. There are all these different kinds of sexual and gender-based violence, which I'm not going to read to you, but it's important to remember that all except the last three on the bottom right can happen to anybody. The last three on the bottom right tend to be confined to people who are identified as female in their society. But anybody can experience all of these other things. And there are sort of systemic societal risk factors, which you see listed here. Some are cultural, some are legal. They're kind of embedded in the culture or the society in which these abuses take place. And then there are individual risk factors, which are, for those of you who do asylum work, are sort of immutable characteristics, right? You can't change if you're born as well, you could surgically, but ultimately, in most cases, you cannot change the fact that you were born female, or that you are a child, or that you are in the LGBTQ community, or that you are disabled, or that you're, these are all really quite immutable categories of people, and all of them are at risk for all kinds of abuse, including and particularly sexual and gender-based violence. So we also know that these phenomenon increase in humanitarian crises, and all of these types of crises, again, we make categories because it helps us count, but they are all overlapping and interrelated and intersectional. And there is really a cycle of violence that begins pre-birth with prenatal sex selection and abortion, all the way around to abuse of the elderly female. And in there, I have an arrow. There's an arrow. All of these are exacerbated in the setting of forced migration and COVID, either or, both. So this is just to sort of bring it to the asylum clinic space. This is from a paper that I did with some students at Cornell, and we looked at 85 people who identified as women, whose cases had been taken on by the WCCHR. We reviewed all of their affidavits, which was, I have to say, one of the most distressing things I've done. And we coded them. And we found that almost all of these women had suffered all three categories of abuse, and at the hands of multiple perpetrators. Almost everyone had suffered abuse, at least at the hands of two, and many by more. And we also know that there are a lot of women missing because of all these forms of abuse. In 2020, the UN estimated that almost 150 million female humans were missing from the world as a result of ongoing sexual and gender-based violence in the cycle that we just looked at. I'm not going to beat a dead horse. So we know it's bad. So one of the so are you guys all still? Yes, you're all still hiding except for Victoria. Okay, I just wanted to check. So if you look at homicide, this was from 2018, and you use it as a proxy for physical violence, because death is the ultimate end point of extreme physical violence. We can see that the antecedents to female homicide that they found in this study really reflect a lot of the conditions that we mentioned earlier on. And even though we talk about homicide as mainly a burden on men, when you break out homicide into intimate partner and family related homicide, all of a sudden it's actually the women in the family who are dying more often. So most of the male deaths live in the space of war and gangs and violence. Outside of the family, most of the violence against women and girls lives within the family. Honor killings is something that we tend not to talk about too much, but it is increasing with the phenomenon of COVID and forced migration. And even though we think we only know about 5,000 cases, when you look at the newspapers and you see that, for example, in Iran, they expect over 2,500 cases in just 2020 alone, that makes it obvious that we're undercounting that phenomenon in particular. In terms of sexual violence, we tend to count it more in conflict-related spaces. I think that's partly because there are more observational groups there to count. It's harder to count when this is happening at home, but the International Criminal Court has defined 7 distinct forms of sexual violence, and it is really important to remember that female perpetrators exist and male victims exist, even though we don't have a lot of data about it. We have a lot of anecdotal evidence. And the numbers are pretty staggering. These are old numbers because it takes a really, really long time to count. So Rwanda's genocide, 500,000, Sierra Leone's civil war, Bosnia-Herzegovina in the 90s, DRC of Congo, this is way off because it's still considered to be the sexual violence capital of the world. And we don't really know what's happening in Yemen, Syria, Ukraine. Most of these are undocumented and never prosecuted. And this is just to show it's all over the world. So I try really hard to make sure that no one thinks it's one particular place, one particular group, one particular area. This happens to everybody all over the place, regardless of where you live. I wasn't sure if we should leave this in. There's just a couple of slides. But again, we're going to bring it back to the COVID and the issue of forced migration. So I think I'm not going to have to convince you guys that it's a human rights violation. What I do want to point out again with the map is that it's not just an African problem, it's a worldwide problem. And what we're not seeing in this map is sort of what's happening in receiving countries from immigration, and the fact that a number of countries, including our own, have our very own traditions of genital cutting of females. And when we look at the data, this is a paper I did with some students from Mount Sinai, and this one from Georgetown. There's a lot of overlap, which is just the point, right? These things do not exist in isolation. Generally speaking, women are going to suffer multiple forms of violence. And we're going to sort of skip over the types because I don't think that's that relevant to this particular talk. Human trafficking is another piece of the puzzle that has changed a lot with COVID. We think in 2022 that about almost 30 million people, well, almost 50 million people are in some form of trafficking or modern slavery situation. About 30 million are in the space of forced labor. It's the second largest criminal industry in the world. And when you listen to some of the traffickers talk, they prefer trafficking humans because they can be reused. If you traffic in drugs, once it's used, you can't use it again. So they tend to prefer trafficking in people. Women and girls make up a large percentage, as do children. The sexual exploitation space, again, we count women. There are probably a lot more men and boys in the sexual exploitation space than we know. And it's really important to remember that forced marriage, and again, that's going to come up in terms of COVID and forced migration, is also a form of human trafficking. And 66% of the people who are affected are women and girls, which obviously means there's a substantial portion of boys who are also part of forced marriage trafficking situations. This is, again, my nod to the fact that it's a global problem. So it's everywhere: high income, low income, Africa, Asia, America, adults, children. And one of the things that we've seen between 2016 and 2021 is that there's been a marked increase in trafficking, both in terms of forced labor and in terms of forced marriage. And probably the biggest driver of this is forced migration coupled with COVID on top of that. So forced marriage is another thing just worth explaining. It's not always about children, although that is how we tend to conceptualize it. When the global estimates folks looked, there were people all the way to age 69 who were in forced marriages, and I've certainly had cases of forced marriages of adults. So, and that often happens in the context of what's called a levirate marriage, where if you're married to a man, if a woman is married to a man and that man dies, the woman then is considered the property of the next in line of the male, not descendants, of the men in the patrilineal side. So very often you'll have adult women forced into marriage to their husband's brother or to their husband's uncle or to their husband's cousin, if the husband is dead. So, but the people who are forced to marry under the age of 18, the vast majority are girls being married to much older men. And the reason we consider it trafficking is that there's usually, it fulfills the requirements to be considered trafficking. There's a financial transaction, there's forced work, there's forced sexual servitude, there's usually coercion or deception, and it affects poor girls more often than wealthy. So what happens with forced migration? So just to talk about definitions, so there are refugees, migrants, and internally displaced people, and they're all people who've been forced to migrate, right? So refugees are specifically people who are crossing international borders due to armed conflict. Migrants, which is the word we hear mostly at the border right now, at the southern border of the United States, are crossing international borders for non-conflict reasons, and gang violence does not count as conflict under American asylum law. So armed conflict usually refers to government actors. And an IDP, internally displaced person, is someone who hasn't crossed an international border but has been displaced from their primary place of residence to another part of the same country. So at this moment, we have, for the first time since World War II, got more people moving in the world than we have ever seen before. Almost 84 million people by the middle of 2021. And about 50% of the refugee population and 50% of the IDPs are women and girls, and children are about 42%. We have no current numbers for Ukraine because, right, there's a delay. But this is just going to grow a lot. And now we have Syria and Turkey's earthquake. So again, and we're talking millions of people. I think we're up to 39,000 people died in that earthquake now. So you probably have to triple or quadruple that for the number of people who are now displaced and homeless and will be on the move. And again, it's pretty split. Forcibly displaced people are mostly young, mostly 18 to 59. So that makes sense. Able-bodied, pretty evenly split between the two genders because that's how the data is collected. So apologies again. So this all adds up to about 1% of the world population. I wouldn't, and notice that the big number here is Venezuela. This is they haven't counted anybody from Ukraine yet. They haven't counted the recent earthquake or any of the newer disasters. This is just from the UNHCR's website a couple of days ago. These are the 5 countries. So Ukraine is in the picture here. Syria is in the picture. Venezuela. This is going to swell. Interestingly, 36% of them are hosted in 5 countries, and it ain't ours. And this is just Ukraine because it's kind of the freshest in the news, but these numbers are pretty staggering when you add them all up, right? 8 million people are on the move. And this was from 3 days ago, 21,000. So the numbers are still going up, and we have no idea what's going to happen, but it can't be good. And there will be millions of people moving. So what happens? Sexual and gender-based violence, if you think back to some of those social risk factors, the dissolution of social order is permissive for sexual and gender-based violence. And that is why it increases fundamentally in the space of forced migration and in the space of COVID. And they're probably additive when they're overlapping. Because the social constraints on behavior have broken down as society falls apart, as people are moving, they're in refugee camps where there's no rule of law, where the traditional family protectors might not be present anymore. It can prompt some pretty desperate actions. And then we have our own special place in this because of Title 42, which is still in effect, and the MPP, which was rescinded. But at the end of the day, we've created this massive humanitarian crisis on the southern border because of our governmental laws. And so we have this huge space of people who've been forced to migrate, who are in incredibly dangerous positions, social spaces, and who are at huge risk for disease spread, including COVID as well. And we know, I'm going to guess everybody on this call reads all the stories about all the terrible things that are happening in Matamoros. And I personally hold my government quite responsible for those things. And so we know that not just in conflict, post-conflict, but in all of these settings, there's a breakdown of the rule of law and security. Although for gender-based violence, the legal space is not always that safe, right? So a lot of women will go to the police and say, oh, well, this terrible thing happened to me, and they might do another terrible thing to her, or they might say, well, that's your problem, it's in your house and it's your husband, and so you just have to live with it. There are often changes in traditional gender roles. So sometimes it's the women who can make the money when there is this social upheaval, and that creates a lot of angst on the part of people who were traditionally in charge and primary breadwinners in the society. And then that comes out as a form of sexual and gender-based violence. Sorry, that's my cat. There's a loss of economic and social capital. And then a lot of space for extremist ideology to spring forth. I'm hoping that, I don't know if you can see my cat here, but he needs to be in it right now. Sorry, Charlie, you can say hi. Hi, Charlie. So all of these things start to increase in those situations. And in refugee camps, there is an additional issue, the lack of private toilets, the lack of menstrual hygiene supplies, clean water, cooking fuel, durable shelter. Those all tend to be the purview of women. And so a huge problem that I witnessed myself when I was working in Haiti is that the women were responsible for the water, getting the wood or the charcoal, and the farther they had to walk to find clean water, the more likely they were to be assaulted on their way to or from. Same problem with the toilets. There were no toilets. There was nowhere to bathe. You had to bathe in public or you had to not bathe. And either one presented a danger. In Haiti, in particular, in Port-au-Prince, after the earthquake, people were living in those UNHCR tents, which are white, and then you'd have a flashlight inside. And so you could see women's shadows undressing through the tent, and gangs would come in and they would just slice the tent with a machete and they would rape all the women in the tent. And that was possible because there was no, well, again, Haiti is no infrastructure now too, but there was a little time and space there where it was a tiny bit better. But there was no way to monitor what was happening. The aid agencies were beyond pathetic in terms of monitoring the situations and creating safety. And the local authorities didn't really own the international relief effort. And it's one example. It's one I happen to know a lot about because I spent a lot of years going back and forth. But this is what happens in many, many, many IDP camps or refugee camps. In Haiti, it was estimated that about 90% of women and girls in Port-au-Prince had experienced rape in the camps. So then that's really depressing. And then you have to add COVID-19, which just added another layer of chaos to what is already a pretty chaotic world. I mean, those of us, I don't know if you guys got to stay home. I worked all the way through COVID and the lockdown, but a lot of people stayed home. My friends were like, "Oh, you have to work?" And they're hanging out, they're working from home. It's all good. But it wasn't. So it's called a shadow pandemic, for good reason. And the UN made a lot of projections. And again, because of the delays in the way we count and delays in data collection, we don't actually know what the true result is. But we know that since the pandemic, there's been a huge increase in intimate partner violence. And if you look at those bottom squares, those all line up with that sense, with the issues of social dysregulation and right, security, health, money, cramped living conditions. A big problem was that people were locked inside, and so they're locked inside with their abusers. Not just adult women, but children. Children weren't going to school, so the teachers weren't there to observe that this child came in with bruises or was acting strangely. And if any of you took the subway, well, for those of you, you're not all in New York, but for those of you who are New Yorkers who took the subway, it was pretty creepy. To be the only person for like the whole train, which was also permissive for some pretty scary things to happen. So I think this just restates from 2020 what happened. But the other thing that happened is that the services went away. So not only were people in higher risk situations, but the people who could help them were not around. Everything closed. So in New York City, when I had a patient, at this time I was working in East Harlem, if I had a patient who had experienced some kind of intersectional violence, it used to be that I could send them to the Family Justice Center. There's one in each borough in New York City, and it's a multi-specialty, really interesting idea that has legal services and domestic violence services and child support services all in one roof, but they all closed, all of them. They just shut down. So there were not only there was an increase in events, but there was also no recourse. And that was just in New York. So it was true all over the world, really. The UNFPA projected that after 6 months of lockdown, there would be an additional 31 million cases of sexual and gender-based violence. Every additional 3 months, about 15 million more cases. There was an estimate, which has begun to be borne true by some preliminary data, that FGC increased because the prevention programs were gone. Child marriages, also a lot of the activism and the protective programs vanished in the pandemic. And some were completely decimated, and some just sort of went quiet for a while and are starting to make their way back. the other thing that's really important to remember is that this also decreased the availability of healthcare for women. And so you have issues of unwanted children, too many children, no contraceptives, children of rape also increasing. So since the pandemic, and again, this is 2021 data, they asked a lot of people, mostly women, again, always, this is all put out by UN Women. So they only collect data in the gender binary about women. It's a little bit of a problem, but there was an increase across the board in sexual and gender-based violence, whether you were unemployed, whether you were rural, whether you're living with children, whether you were married, whether you were food insecure, people saw more violence and experienced more violence. And this is really more numbers. And I would say in my own practice, this was 100% borne out in terms of the people that I was seeing at clinic. And the other thing that happened is that women disproportionately lost their jobs. And so when women lose their jobs, they become dependent usually on a male person who then can exert more control over them and exact a price for the monetary or economic support. And I see that all the time in New York in real time and in the stories that my patients tell me from their home country. And then this is just to go back to unintended pregnancies and contraceptives, I think a really important piece, because when you have unintended pregnancies, that contributes to the social disarray. It also contributes to the hunger and the economic dependency. It just feeds the cycle. And adolescent girls are probably at the have an even higher risk of abuse, in part because of issues around, well, a higher risk of mortality because of issues around pregnancy care, unsafe abortions, and then long-term disruption of education, food insecurity, and all of that tends to lead to increases of child labor, trafficking, and child marriage. So we know that during COVID, this is UN Women again, they asked, I think, 500 some odd women from several different refugee camps what they were seeing when the women who had lived in the refugee camps pre-COVID and then were continuing to be there during COVID. I don't think we can say post-COVID yet. And they all saw increases of intimate partner violence, either experienced by themselves or witnessed, sexual violence, and early marriage. So why do we not hear so much about it? We don't hear about it because there's really no investment in data collection. That's always how it's been, but it seems worse now. So I would encourage you guys to consider that for those of you who might have MPHs. I left out, there's some interesting data in Bangladesh that sort of brings all of this together. So in Bangladesh has been tremendously affected by climate change, which has caused a lot of internal movement into refugee camps, breakdown of society. COVID came, made it even worse. Economic insecurity. There has been a radical change in Bangladesh in the rates of child marriage. So on the one hand, this is a tradition, a space where the tradition is that there's a dowry. So and the girl is worth more the younger she is, and the family can't afford to feed that girl, so it's better for them if they don't have her in their family if she goes off to be with the husband. So it's a short-term gain. They get money, they lose one mouth to feed. They also, there's a perception that it's safer for a 10-year-old to be married to a 40-year-old because then somehow she's protected from rape. Although the idea that a 40-year-old with a 10-year-old isn't rape is a little mysterious to me, but that is the general perception. And so it just keeps cycling. And the rates of child marriage in Bangladesh, and it's not just Bangladesh, it happens to be where the data was collected most recently, is huge. And the drivers are this social dissolution in the face of climate disaster causing internal displacement coupled with COVID. Okay, so that was really depressing, sorry. So what can we do? I would love to hear what you guys feel like we could do. To me, the data is so important. I am not an MPH. I will forever feel sad that I do not have an MPH, but I don't, and I'm not going to get one now because I'm too old. But I do a lot of research and I do collect data. And data doesn't necessarily mean you publish a paper. Data means that you do a proper violence history when you see your patients in clinic. I ask every single person, I'm a gynecologist, so it's almost always people who identify as women, not exclusively, but I ask everyone who walks into my clinic office, you know, have you ever experienced X, Y, and Z? It's just part of my history. It goes right along with that sexual history that nobody wants to take. And if you are ever a student of mine, I'm going to make you take that history. But I think that's really important because it's not just the macro data, it's the micro data. And what can we offer that individual person as relief, not just programmatically, although programmatically is really important too. It's also important to educate your colleagues. I think people don't think of asking the questions. People are uncomfortable asking the questions. And a lot of times they feel like they don't know what to do if the answer is yes. So, but we're very lucky. For the most part, I'm guessing all of you are medical students, which means you're all in large academic institutions, which means you all have departments of social work and you have access to some kind of intervention. So again, there's a micro intervention and there's a macro intervention. Some of these other ones, other students have come up with them, but you know, financial investments, whether they're in your own neighborhood. I live in Brooklyn. There's a big drive to collect money for some of the refugees who've been bused in New York City. Or, you know, maybe you get more at the programmatic or policy level, which I find soul-sucking. But my sister is a policy wonk, so it's not for everybody. Thinking about what can you do with your phone? Can you recycle your phone? I used to bring phones with me to Haiti all the time so that people could call and increase the social calling, not just because they're in trouble, but because it also helps preserve the social structure and the accountability that can help prevent some of these issues. Legal strategies, enforcement is really important, but I'm not a big fan of enforcement and punishment as a first pass, because it's a hammer. It's not subtle. And I think it doesn't always take into account some of the larger social issues. Education, economic development, working towards a decrease in gender and gender-based discrimination. So what do I do? I mostly provide service to individuals, although less as I move into more administrative spaces. But I think cross-sectoral collaboration is really important. I think we end up siloed very much in medicine. We talk to other people like us, as do we all in all social settings. One of the things I love about the asylum work is that we talk to attorneys with whom, for the most part, we have very adversarial relationships, especially as an OBGYN. So it's really nice to talk to attorneys, but also to, in New York City, we have a cross-sectoral group that's Mayor's Advisory Committee on Female Genital Cutting. So there are educators, there are nurses, there are doctors, there are law enforcement, and that's where the powerful interventions come from. Writing papers is really important. Teaching is really important. And you can teach even when you're a student, and you can be an advocate. And I personally love tangible success, which is why I love doing asylum cases. If you ever have any doubt about the impact that we have on asylum, there are papers out there, which a couple of them I helped write, but ultimately there's nothing that feels so good as when a lawyer calls you and says that somebody got asylum because you were able to help them. It's life-changing. And in case you start to feel overwhelmed, I will leave you with this, which is above my desk, because it feels very overwhelming sometimes. And I think we all have our own trauma around COVID, and many of us will have statistically endured some sort of sexual and gender-based violence ourselves. I think it's important to think big, but also to stay focused so that you don't get overwhelmed. And remember that every little thing that you do is helpful. So I'm going to get off my soapbox now. And I'd love to know if you guys have questions. I'm going to take this down. I'm going to stop sharing if I can.
Thank you so much for that presentation, Dr. Ottenheimer. That was fantastic. I was screenshotting a lot of your information for my own reference.
Well, it's all going to be recorded.
It will, but for my own quick reference, since I think a lot of those stats are pretty new and really meaningful. Yeah. I had a question about the link actually for the organization that you donate to in Brooklyn for newly arrived.
Oh, yeah. So I donate to it. They're sort of a dual. It's called CHIP, C-H-I-P. Are you from Brooklyn?
Not from, but in New York often, so I'm curious.
Yeah. So CHIPS is a local food pantry and soup kitchen on 3rd Avenue that used to serve mostly men, homeless, working. And on top, they have a shelter for pregnant girls, teenage girls. And they are now like overwhelmed with mostly Central Americans who have been bused to New York. So that's where we spend time and money. So it's CHIPS, all capital letters, and it used to be a Catholic organization. They renamed themselves, so it's still CHIPS, but it's not Catholic.
I think I just found it online. Thank you for sharing.
Yeah, they're amazing. And actually they're when I was in private practice, their executive director was my patient. But we've served meals there a lot.
Thank you so much, Dr. Ottenheimer. Just to echo what Victoria said, so much great information. And I think one of the points that you were kind of discussing with research was really interesting to me. Like how do you see research in the macro data sense kind of interfacing with policy? Like how do you, when you find results and you want to kind of scream it to the world, how do you make that happen? And any advice for that for those of us who might be collecting even macro data?
Yeah, I mean, I think the thing to remember is that you need money to exact change, and the people who have the money want the numbers. They're not going to give you money because you have a great idea, and they're not going to give you money because it sounds good, and they're not, unless you're independently wealthy, right? So there's that, right? Sean Penn, for example, in Haiti. But so I think publishing is really important. And and it's expensive and it's very difficult and exhausting, but it's once you have a paper in the academic space, people take the data much more seriously. And the trick for med students, I think, is to find a mentor who's interested in those things. I mean, when we were talking earlier, I said I went to University of Pennsylvania, and I apologize to anybody who goes there. But in 1990, they were not at all interested in the things I was interested in. And I had a really, really, really hard time finding a faculty mentor who had any interest in this kind of data collection. I think it's a little bit better now, depending on your institution, but I think trying to get into that publication space is really important, because then when you go to funders, you can say, there's this evidence and I helped create this evidence, and so you should give me more money so that I can create more evidence and then create programming and then engage in self-reflective data collection. Don't get so this happens all the time. Don't get so excited about your own idea that you're afraid to look back and do an honest assessment of whether what you're doing actually makes a difference, because it might not. And it's something that NGOs are very bad at.
Go ahead, Victoria, it's all you.
I'm just curious, Dr. Arnheimer, since you bring up the idea of an NGO, in your experience as a physician, have you found that it's easy to collaborate with NGOs and bring this research-based advocacy perspective, or not too much?
Not so much. It depends on the NGO, to be honest. I think I swallowed some pretty bitter pills in Haiti. And so I'm very leery of the large NGOs. I will never give money to the Red Cross again as long as I live. And then the little ones are so driven by personality. It's very difficult to find one that is interested in really honest quality improvement, right? In reflecting honestly on their outcomes, and whether you spend 90% of your money on whatever your project is and only 10% on your staff, that doesn't mean it's a good project. That just means that's how you spend your money. And I think we are notorious as the colonizing global north is notorious for imposing solutions that we think are good on the global south that often don't do anything great, sometimes do great harm. And very slowly, I think because of publications and data, we start to hear things from like the UN or UNICEF, like, we ask the community we want to serve what they would like to have. And that's becoming more normalized. And I think that's the only way we're going to address these sort of social dissolution issues, because what might work for a displaced group of people in Panama or in Mexico is not the same thing that's going to work in Sudan, because the social constraints are different, and the things that need to be repaired are different, and the things that people will respect and take seriously are different. That wasn't that helpful, was it? Sorry.
No, it is. Just hearing your personal perspective going through the process is helpful. So thank you.
It can be really discouraging. I spend a lot of time looking for organizations that are willing to be self-reflective in an honest way.
Thank you again.
If anyone else has any questions, please feel free to either unmute yourself or put it in the chat. But if not, I just wanted to ask one more question, Dr. Onheimer, while we have you. I know you were talking about, having a formal training in public health, And obviously you are so well versed in that area, even without an MPH. I'm kind of curious, like, can you talk about paths to get involved in public health and global health, even outside of, again, that formal degree, in your own experience? Because I think that's so inspiring and exciting to see that that's a possibility.
I think you just have, I hate to say it, but you have to make your own opportunities. I'm that person who cold calls people. I do. And I was going to get an MPH, and there were circumstances that prevented me from getting it. And I think it at the beginning, it might have given me more credibility, but I think if you literally just keep doing the work and align yourself with other people who have the skill sets that you don't, be honest about what you don't know. So I have a good friend who I've written a lot of papers with, and she is great at the numbers. I'm not that, conceptually I'm fine at it, but I can't do a chi-square. I don't really know what that is anymore. But I don't have to, because I understand the concept. And so if you align yourself with a team, an interdisciplinary team of people who have a large skill set, then you don't have to have all the skills in your own head. And that is really helpful. I think we as a tribe, a medical tribe, we are not very well trained in collaborative efforts across sectors. But that's really where the impact is. And recognizing what you don't know and seeking out someone who can fill in that gap, and filling in the gap that of knowledge that you have for them is usually a really good strategy.
Awesome. Thank you so much for sharing that. And I'm going to stop the